Thank you very much. As he said, we will be talking about improving substance abuse treatment outcomes, specifically going over a machine learning model that we created to predict readmissions with high accuracy. We will specifically be talking about how this can be used to personalize treatment. Today, we will actually not be speaking officially on behalf of our workplaces because this was a passion project for us that we did outside of work. So happy to show it to you, and I'll get started. So we created a model that predicted with high accuracy which patients will relapse from substance abuse treatment. The idea here is to understand the risk so that we can then mitigate it and use this for personalized treatment. We use both the model and model explainers in order to open up the black box of the machine learning model, not only to understand what was important overall for predicting risk, but also on an individual level for each patient, understanding what contributed to their particular prediction. The idea here is to take into account individual risk factors in order to personalize treatment and maximize patient success. This is a great example of how you can pair a model, which would be useful on its own, with explainable AI to really open that up and get more value out of it. And our project culminated in a user-friendly dashboard that we plan to make available to practitioners in order for them to, real-time with patients, make better decisions and help reduce and prevent readmission. Now I'm going to talk a little bit more about the background of the problem so we can all be on the same page when talking about the model specifically. As all of you know, probably because you're sitting here, substance abuse is a very serious problem in the United States. Two of the visuals shown on the screen really show that. The one on the left is the US monthly overdose deaths. As you can see, in the past decade, they've been going up steeply, but particularly during COVID, they have gone up a lot more. So it's become even more of a serious problem. The graph on the right shows a little bit more about why that is occurring. This particular graph contains data from all publicly available admissions in publicly funded admissions into substance abuse treatment in the United States. This is the data that we built our model with. Specifically, it's showing the primary substance at admission for each of these patients. As you can see, as time has gone on, in 2005, about half of admissions were comprised of alcohol and marijuana. But if we look now in 2019, a much larger proportion are hard drugs, particularly opioids and heroin. Because these drugs are a lot more addictive, lead to relapse more often, and they contribute more often to overdose deaths. This helps explain why the rise in overdose deaths is occurring. The idea here is to try to mitigate this problem. Our tool is not going to be the be-all, end-all, but we want to help move the needle to improve this problem. Now to talk a little bit more about the data set that we use for this particular project. We use the Treatment Episode Dataset, or TEDS, specifically focusing on admissions. This is publicly available, and it's built by the Substance Abuse and Mental Health Services Administration, or SAMHSA, which is funded by the federal government. It includes all state and federally funded substance abuse treatment admissions. So with that in mind, this model will be better used, at least right now, on high-risk populations. That comes from being a high percentage of Medicaid as well as grant-funded admissions. Our observations are at admission level. This is really important because it is a limitation of the analysis as of now. The data is not historical or longitudinal in nature. For example, if someone came in twice in 1 year, we would not be able to link those two admissions to be the same person. So with this in mind, we created a model with the target variable, or the variable we are trying to predict, to predict whether admission was a first-time admission or a repeat admission. And by repeat admission, I mean they've been in substance abuse treatment before that particular admission. The idea here is to really understand the risk of substance abuse, the risks associated with substance abuse treatment and their admission, so that we can tailor treatment to those individuals. Now I'm going to go on a little bit more, now that we've had background, onto our final model and the evaluation of that model, so that you can understand better when we show you the dashboard at the end of our presentation. Our final model ended up being a random forest classifier. We went through an extensive grid search. We tested over 100 models to try to find the model that was the best one. We tested multiple different types of models or categories, specifically random forest, gradient boosted trees, XGBoost, deep neural networks, and lasso and ridge regression. By far, random forest came to the top as being the most effective in this particular case. Not only did we test these different types of models, but we tested dozens within these model types themselves. So we did an exhaustive hyperparameter search by tweaking those models and trying to get those models to be as good as we could. Shown on the right are the final evaluation metrics of that model. In particular, we had an accuracy level of 88%, a precision of 89, and a recall of 91. Now to dig into those technical numbers a little bit more for those of you who may not be practitioners in data science. Shown here is called a confusion matrix, and it talks a little bit more about the false positives and false negatives, really what those numbers that I just showed actually mean in practice. As you can see here, the shaded boxes are those values that our model predicted correctly. So on the top left-hand corner, with the blue box around it, you can see that 33% of our sample we correctly predicted as a first-time admission. On the bottom right-hand corner in the green box are those that we correctly predicted as a repeat admission or having 2 or more admissions. The lighter shaded boxes are those that we incorrectly predicted with our model. At the top, you can see those individuals that were actually first-time admissions, but they were in reality the 2 or more admissions, so a false negative. You can see on the bottom, the false positives were 5%. So they were actually a repeat admission, but we predicted that they were a first-time admission. As you can see, there's a healthy balance between the false negatives and false positives. But we did choose a model deliberately that predicted the high-risk patients and better than the low-risk patients, just because of the high risk and costs associated with saying that a high-risk patient was actually low risk. Now I'm going to dig a little bit more into the feature importance that came out of the model itself. By feature importance, I mean the variables that the random forest classifier told us were the most important in this particular case. You can see the top 6 in this particular case. The ones colored red are, as the value increases, the probability of readmission increases. The ones that are green, you can see as the probability increases, or as the number increases, the probability is decreasing. Now the top 2 factors might really surprise you. It definitely surprised us. We definitely looked through, made sure they are correct. So the top 2 factors that are associated with higher probability of admission are higher education and lower frequency of use. This was extremely surprising to us. So I looked a little bit more into why this might be happening, because it's the opposite of what I expected. So these are just hypotheses, not a causal analysis by any means, but we found that highly educated individuals in substance abuse treatment are less likely to complete treatment, meaning they're not doing the recommended physician recommended course of treatment. So they may be likely, in this case, as the model shows, to be readmitted to substance abuse treatment. On the other side of the spectrum, those individuals who use drugs more frequently are not only less likely to complete treatment, but they're less likely to seek treatment in the first place. So they may not, when coming in, complete treatment just as the higher educated didn't, but they may be less likely to come back, showing that there is a decreased probability of readmission. So that may explain a little bit why we're seeing these numbers. Other important factors were age group. As age goes up for admission, a probability of readmission increases. Age of first use was also extremely important. As the age of first use went up, the probability of readmission decreased. And having the gender female and living in the Pacific division both decreased the risk of readmission for this particular model. Now, moving on from the model evaluation and the model itself to actually a technical deep dive on the technologies we used. Since we're at the Databricks Summit, that's definitely an important part of this project. We used a wide variety of technologies to accomplish this goal. As you may expect, we used Databricks for this particular project. We wanted to have the scalability of Databricks. We did end up using Python versus PySpark for this particular case, so that the model would be more portable to other different technologies and more cost-effective for real-time deployment. But Databricks scalability helped us do that extensive grid search. And those 100 models that we did mostly comprised of scikit-learn and Tensorflow models. We also, as I said, did use some XGBoost models as well. We also heavily leveraged MLFlow. As Jennifer can say, she was on my team. I always made my entire team use MLFlow. I'm a huge fan. So we use this for tracking our model evaluation metrics during training, specifically accuracy, F-score, things of that sort. But we also used it and leveraged it for our model artifacts as well. So logging CSVs of our feature importance, logging images, and logging confusion matrix. All of that was put into the user-friendly UI that MLFlow provides, so that we could very easily choose from a long list of our 100 models which one was the best for our use case. And finally, the project's culminated in a Power BI dashboard, which you'll be seeing in a few minutes. This particular dashboard helps inform clinical decision-making by using explainable AI for us to understand risks of readmission for clinicians. And we plan to make that available to clinicians in the future. So ultimately, our particular solution is designed to help personalize and improve patient treatment. As you saw already, we predict with high accuracy those patients who are readmissions to substance abuse treatment. And we also use model explainers to not only understand at a high level what was important, but at an individual level as well. I'll give a little bit more information on why that's important. I'd like to give an example. So we want to use those model explainers to personalize treatment, as I said. So what does that mean? What does that look like? So high-risk patients, for example, we may want to vary treatment length based on risk. That's one possibility. Another possibility is focusing on individual risk factors for each patient. For example, say a patient comes in and one of the most important factors that are making them high risk is that they're unemployed. So if that was the case, the program could then, after the program completed, refer them to an employment agency, make it more likely that they become gainfully employed, and they might be less likely to be readmitted to substance abuse treatment. It's really understanding why that particular individual was high risk and trying to mitigate based on their personal characteristics that's important here. Shown here is a healthcare provider journey so that you can start to understand how this could actually be used in practice. In this particular case, the patient would go through patient intake. They would gather characteristics about the patient like they normally would. that would log the information into the system and help obtain both the predicted probability or the risk for that patient, as well as the individual model explainers for that particular patient. And that information could be used then to tailor treatment for that individual patient. But also, the Power BI dashboard shows a much broader view of patient outcomes and patient explainers as well, so that that particular clinician can go in and understand their patients, how they change over time, and what they look like at a global level, as well as at an individual level as well. So this solution definitely isn't going to be the be-all, end-all. It's a very complex problem with a complex solution, but the idea here is for healthcare providers to pair this particular tool with their training, experience, as well as their patient interaction to help inform decision-making. It's really another tool in their toolbox to help improve outcomes. In just a moment, we will move on to the dashboard demo. I'll be handing it over to Jennifer so she can go through that interactive dashboard with you. But I want to go over one concept before I hand it over to her, just so we can really understand what model explainability is and what our model explainers have and what they measure, just so everyone's on the same page for the demo. In this particular project, we used model explainers, and really what they do is try to help quantify, both at a global level and an individual level, the contribution of each variable or feature in your model. In particular, we use shapely values for this to help quantify the contribution of each feature. In the visual on this particular slide, you can see one individual. So we randomly chose one person out of our sample as an example here. This particular individual had a predicted probability of 0.25. What that means, it's below 0.5, so they were predicted to be a first-time admission. So predicted to not have gone to substance abuse treatment before. And it shows in decreasing order for that individual which features were most important. In this particular case, being in the age group 21 to 24 was the most important for this patient. And it actually was very significant. It decreased the predicted probability by 0.11 or 11% with that feature alone. The next most important was that they were employed full-time, so that further decreased that predicted probability by 0.04 or 4%. On the other side of the spectrum, not going to self-help programs like Alcoholics Anonymous and Narcotics Anonymous actually increased their predicted probability by 0.04% or 4 or 4%. The idea here is the starting point, or the place where everybody starts with these model explainers, is the average prediction, which is 0.67. And then if you add up all the contributions for all the features, it's going to equal their final prediction, which is in this case 0.25. So really trying to understand the individual risk factors is the goal here in this particular case. So now I'm going to turn it over to Jennifer so she can talk with you and show you a little bit more about our user-friendly dashboard and walk you through more of these explainable AI and model explainers.
How many people in this room have been affected by addiction in some way, whether that be a friend, family member, or colleague? On the other side of the coin, how many people in this room have someone who they know, a close family member or friend, who works in the healthcare industry these last 3 years? Both patients and clinicians are subject to the elements in their environment that are sometimes outside of their control. For example, as Kelsey and I were digging into this data, we noticed that specifically in the Northeast region of the United States, patients in that area had an average of 81% predicted readmission. Clinicians have been through a lot with COVID the last 3 years and often suffer from burnout. So what if I told you there was a way that we could use the data that is very simply collected at time of admission, either on a clipboard or an iPad, to create a set of tools in a toolbox for this clinician to use to provide the best route of treatment for the patient, specifically designed and catered for them based on these characteristics. These are the reports that we'll see in this dashboard. This first report gives you an example of the following attributes to assess a patient's risk. It does two things. It shows you the underlying data that supports the prediction, and it also shows you the average prediction, which is calculated by the selection of demographics, of information collected at admission, and historic drug use. So for example, if we were to look at an individual between the ages of 40 to 44, a female, residing in that northeast region, who, at the time of admission, was brought in on an ambulance and experienced their first drug use between the ages of 12 and 14. We see that we have over 8,000 patient matches within the data to support this prediction. Out of those 8,000 patients, 60% of them have substance dependence. Of those 60%, on admission, they had an average of 1.7 drugs in their system. And the fact that these patients used their first drug between the ages of 12 and 14 increased the average variable contribution to the predicted probability across these patients by 2%. The second report, just adding to those tools in the toolbox for the clinician, gives a view about the data in specific groups and the population of patients within those groups, while also showing you the average prediction of readmission based on the specific features and attributes of that population within the group. So we see, for example, that the age group of 30 to 34 makes up 17% of the data. Of that age group, on average, they're at risk of 62% predicted readmission. Females make up roughly 40% of our data. Their average prediction of readmission is over 58%. In the Northeast region, which makes up 29% of our data, we notice that their average prediction for rate of readmission is over 81%, as noted earlier in the presentation. Now, the last tool within the clinician toolbox really dives in deep into the information when we're explaining feature importance. When a clinician is trying to find the best route for a patient, they want to focus on things that will give them a greater probability of success so they are not readmitted. These are some of those features and variables that will guide them in the right direction. For example, if we look at the top feature importance by variable, we see that if heroin is present in the system at the time of admission, on average, this variable contributes a positive 3% to the overall predicted probability for this group of patients. We see that when a patient is brought in by an ambulance at time of admission, it increases by 1%, the average overall prediction when we're looking at these patients. If we're specifically looking at age of first use importance based on either readmission or non-readmission, we notice that if we're specifically looking at readmission, these patients who come in or experience their first drug use under the age of 14 have a 2% chance of predicted probability across those patients. But on the opposite end, if we look at the predicted no readmission, we notice that patients who experience their first drug use over the age of 25 have a negative overall percent predicted effect on the data. If the clinician is interested in looking at specific drugs that are in a patient's system once they come in or are admitted, we see, as Kelsey explained earlier, that those who come in with heroin use have an average of 4.6% probability of readmission. Those who come in with heroin use in the system also have a 0.17% chance overall predicted probability for non-readmission. We also noticed that, as Kelsey mentioned earlier, marijuana has a lower effect on readmission when you're talking about someone coming in at time of admission, a negative experience for those who are not readmitted versus a low 1% positive average importance for those who are readmitted. We can also take a deeper dive into feature importance by demographic. We notice that those who come in with a mental illness, on average, have a 2% increase in predicted probability for readmission. And for those who are not readmitted, actually have a negative 1% on the spectrum for predicted probability across all patients. These three tools that are in the clinician's tool belt are a very easy and simplified way, by using the data that is already collected at the time of admission, to create a very personalized program for each one of their patients to help them improve and maximize their success. Thank you.
So should we open this up for questions, since we have a little bit of extra time?
Yeah, we've got a few minutes. If there's any questions, just raise your hand and I'll bring a mic over.
Hi. So I was curious about, I really love the presentation. I think that these tools are great. I'm curious, are you guys gonna try and get ahead of the curve? I know a lot of trends in medicine now, they want to be proactive. So is there any way you guys plan to look at different data sets to see, oh, this person initially seemed low risk, but at their annual health checkups, they're starting to present symptoms that are going to trend them back into that downslide into addiction? Because, I mean, shit can happen. Someone can die, their friends can stop talking to them, and then all of a sudden, there's a needle in their arm and they're in an ambulance. I was curious if you guys, I know the data for that's likely very difficult to find, but I was curious if you guys had plans to research that.
Yeah, definitely. In this particular case, we went with the data that we had, which was publicly available. There's actually a discharge data set, which it's kind of on my list of things to look at that you can pair with this. So that's probably the first part of that. It's during the same visit, but it at least looks a little bit into the future, as well as that completing treatment aspect of it. But the idea here is this would be a starting point, and we want to partner with practitioners specifically to enhance this data set. Because right now it's mostly high-risk patients, and it's not longitudinal in nature, as you said. So the idea here is to actually partner with them in the near future to get that non-longitudinal data into the data set. And something I didn't have time to cover, we're also planning on doing an MLOps implementation as well. So detecting data drift and detecting model drift as well, but really trying to also monitor demographic changes as well. So to make sure our model for all demographic groups is accurate and it's stable over time. So it's a little bit different, but so those are the two in the future, in this near future that we will be implementing.
Sweet. Thank you so much. This is really cool research.
Thank you.
Yeah, great question. We have time for one more.
Hello, thank you for doing this. This is absolutely fantastic. I was just curious, in the data sets that you used, was it medication-assisted treatment or abstinence-based treatment? And I guess, did you pull those apart at all, or did the data allow for that?
One of the features in the data set was methadone. That was the only thing that was available to us, was the methadone treatment. It did not pop up as one of the most important variables in our data set. But that definitely was in the model and considered. It just didn't make it into the dashboard because it didn't rise to the top as being the most important.
Thank you.
Awesome. We could do one more.
I was curious on all the features that you gathered. Was all the data available, or did you have to deal with a lot of nulls? Was everything filled out? Because I know sometimes if I go to the doctor, maybe I might not, I don't know. Try and get through it as fast as I can. I was wondering if you had to deal with a lot of nulls and maybe you had to do some sort of hot one encoding, I don't know.
Yeah, as you can probably see from the facial expression you got when you asked that question, there was a lot of missing data. There were actually features we couldn't use because they had so much missing data. We had to draw a line, really, and so we imputed our data in this particular case. We did go with a simple method for imputation. We tried something more complex, but we didn't see much increase in the accuracy of our model when we did that. But it was a huge challenge. This data was particularly messy, just like in general government data is. But we did go that way. As for one-hot encoding, we definitely utilized a lot of feature preparation. We adjusted the features quite a bit before they went into the model. And in general, did most of the standard steps for preparing our data for modeling as well.
Awesome. Thanks, Kelsey and Jennifer. Can we get a round of applause for them?